ISHBT. Today we have with us Dr. Arijit Nag as a chairperson of the session, and he will introduce our guest speaker of today, Dr. Suparno Chakrabarti. Dr. Arijit Nag is consultant of Tata Medical Center, Kolkata, in the Department of Haematology, Hemato-oncology, and bone marrow transplant. So over to you, Dr. Arijit, to introduce Dr. Suparno Chakrabarti and initiate our 43rd masterclass. Thank you.
Thank you, sir. So it's my absolute privilege today to introduce Dr. Suparno Chakrabarti to this forum. And sir has been a person who has got a great understanding and insight. So it's rare to find a person who has got such a deep understanding on the subject and who thinks beyond what you're seeing clinically, and so that we can foresee what's going to come. So sir is the principal director in the Action Institute of Blood Diseases, Transplantation and Cellular Therapies in Action Cancer Hospital, New Delhi, and an honorary professor in Amity Institute of Molecular Medicine and Stem Cell Research. And today's topic is regulating the regulators, the secret path to transplant tolerance, and wherein we're going to discuss about the regulatory T cells, which we know are central to maintaining immune tolerance and trying to control excessive alloreactivity after stem cell transplantation. I think it's always been the holy grail of dissecting out the graft versus leukemia from the graft versus host disease. And Treg cells have been the central player who's been thought to be to have a central role in maintaining the graft versus leukemia and dampening the graft versus host disease. So it's over to sir to take us through his journey and also to give us an insight as to where this field seems to be headed. So we can see your slides in here.
Okay. We can request all the attendees to please mute your microphones. Except speaker, all the attendees please mute your microphones.
Sir, if you can put, yeah, perfect. Thank you, sir. You can start.
Okay. Thank you, Rajiv. Thank you, Arijit, for inviting me for this talk. So when Rajiv had asked me as to, he wants me to talk on something related to immunology, it was just a couple of months after the Nobel Prize for the year was declared. And when I started my career in medicine, means I was doing my MD medicine in early 90s, regulatory T cells were not recognized. When I finished my Doctor of Medicine from Birmingham University in 2003, regulatory T cells were not fully recognized. And today I stand 20 years later with Sakaguchi winning the Nobel Prize for deciphering the crux of our existence. And I'll tell you why I call it the crux of human existence. It's because that we were born amongst billions of pathogens. Those who have heard me before are tired of hearing the same thing I start off with, that we are born amongst trillions of pathogens, bacteria, virus, fungus, you name it. Human existence came into being amidst these pathogens. So the human immune system was designed to ward off the pathogens or fight the pathogens. And to do that, what was designed were the T cells. So T cells are a part of the adaptive immune system. We have two components of the immune system, the innate and the adaptive. The innate is there to wipe out or wipe up anything that comes our way and present it to the adaptive immune system. So the antigens, the pathogens that the body faces, the innate immune system, antigen-presenting cells, macrophages, dendritic cells, monocytes, and B cells would lap it up and present it to the T cells, the naive T cells. And the naive T cells would recognize the antigen as per their TCR repertoire. And once they're recognized, they are ready to be activated, but that's not enough. They would need a second pathway, which is called the co-stimulation pathway, largely run by the CD28 on T cells and CD86 on the antigen-presenting cells. So once this second pathway is completed, that the CD28 ligates with 8086, the T cells get activated. And once the T cell gets activated, it's an unchecked process of nuclear fission. And when I say it really is, that it's a process of nuclear fission. It goes on in a bombarding fashion. So from one T cell, a million T cells would develop within a period of 72 hours. Now, this process consumes a humongous amount of energy. It is needed initially to control the pathogens. But if this process goes unchecked, human existence will come into question. We cannot sustain this sort of energy expenditure. And that is why, for those who know or seen the cytokine release syndrome under various conditions, would realize that what it entails. So with the humongous amount of T cell proliferation resulting in massive release of interleukin-2 and other cytokines, we are in a situation of explosion. And that is brought under check by various checkpoints in the process of T cell maturation, activation, and finally, they undergo either an activation-induced cell death, or they would go into a state of exhaustion, or they would contract and go into a state of memory. Now, by and large, there are many pathways we call the T helper pathways, because the T cell maturation or T cell activation and the T cell effectorship is guided through various cytokine-mediated pathways. Now, everything is decided by the cytokines. So we call them the polarizing cytokines. Say, for example, if the cytokine is interferon gamma and TNF alpha, in the naive T cells, what would be transcribed are the master transcription regulators, which in this case would be TBET. And if TBET comes into play, then the JAK STAT1, STAT4 pathway will come into being. CXCR3, CCR5 will be expressed, and these cells will then secrete what we call the signature cytokines in the form of, again, interferon gamma, interleukin-12, interleukin-33, and so on. So this is the TH1 pathway. Likewise, there is a TH2 pathway, which is considered to be a perennial, quintessential helminthic pathway, or an allergic pathway, as we might call it. And a third pathway, the TH17 pathway, which is largely a mucosal protective pathway directed towards the bacteria, fungus, and similar organisms on the mucosal surfaces. They all have their master transcription regulator, GATA3 for TH2, ROR gamma T for TH17, and they would secrete their signature cytokines, which will then take the whole pathway down the necessary activity required by the T cells and the adjuvant cells, whether it's macrophages or the monocytes, which will work in an orchestrated manner with the T cells to achieve the target. Now, if that be the case, and this is all directed towards a foreign antigen, the daily example of a human body encountering a foreign antigen is when a mother conceives a child. So when a mother conceives a child, half of the HLA, which is inherited in a Mendelian pattern, would belong to that of the mother, but the other half is that of the father, which in most cases, in non-consanguineous cases, would be a disparate foreign antigen. Then how is it possible that those antigens are in the mother's body and they're surviving for 9 months and giving rise to another life? If it doesn't happen, then there is rejection or miscarriage. And majority of the times, 80% of the time it would happen, and there would be a happy family. Tolerance. So the two arms of the immune system, tolerance and rejection. In 1953, Medower and his two PhD students, Birmingham and Brent, they carried out a fascinating experiment. Medower got a Nobel Prize within the next few years for this work. And this work is the benchmark for human acquired tolerance. Now, what was this work? So they injected mice and or chicken in utero with a third-party antigen, not related, a third-party antigen in utero in the mice. I'm focusing on the mice, not the chicken. The same experiments were carried out in chicken as well. So once that was done, a one-time antigen exposure in utero of the fetus, when these mice were born, they were given skin grafts. It's a common mice experiment, doing skin grafting to look for tolerance or rejection. So they were given skin grafts from a completely unrelated mice. They would reject it, which you see over here in the green color. So the green color is a random donor. So the green color graft is rejected. Now, when they gave the graft from the mice whose antigen was exposed in utero, it was accepted. The gravity of this finding still, resonates and reverberates in everyone who is working with transplant immunology. In other words, acquired tolerance against a third-party graft, a third-party antigen, could be achieved and established if the fetus is exposed to that antigen before birth. And that sets the stage for acquired tolerance or transplant tolerance and the very basis of haploidentical transplantation. Now, mind you, these mice who were tolerant to the third-party antigen rejected every other graft. They would react against all pathogens normally. It was a specific tolerance to that particular antigen because of exposure in utero, which happens to the mice when they are exposed to the mother's antigens in utero. They forever become tolerant to the mother's antigen. And that's why those who have followed the history of haploidentical transplantation would realize that why Franco Aversa and Massimo Martelli told 25 years ago that mother is the best donor. So this is the immunological basis of it. So from here, the question that remains open is, okay, the child is exposed to the mother's antigen and the child becomes tolerant to the mother's antigens, mismatched mother's antigens. But what about the mother? The mother has got an active immune system, and how come the mother is not rejecting the fetus? And that's where enters Sakaguchi. So in 1970s, a group of immunologists pondered that the process of tolerance might exist, the process of T-cell suppression might exist in a cellular form. Until then, what was recognized was that if T-cells are intolerant, they would be clonally deleted. There would be soluble substances which would suppress the T-cells if the need be. the fact that there is a cellular component to suppress the cytotoxic or activated T cells or autoreactive T cells, for that matter, was not accepted or recognized. So Shimon Sakaguchi in the 1980s carried out a series of experiments along with others. There were many others. It's not just Sakaguchi, Konda, Runsdell, I can name a lot of them. They carried out some seminal experiments. One of the most famous experiments is the 3-day thymectomy mice. What is a 3-day thymectomy mice? So a mice, if it underwent thymectomy on day 0, would develop severe immune deficiency. But if a mice underwent thymectomy on day 3 after birth, developed severe autoimmunity. A simple observation, but that changed everything that we know today. So what happens between day 0 and day 3, and day 3 onwards? Two very distinct events are happening in the thymus. So on day 0, take off the thymus, immunodeficiency, day 3, autoimmunity. Or in other words, between day 0 and day 3, there are cells produced by the thymus which are capable of producing autoimmunity. And after day 3, because if you do a thymectomy on day 7, the autoimmunity is much more muted. Means after day 3, there are cells produced by the thymus or substances. At that time, it was thought that there may be soluble factors, there may be other things that are produced by the thymus, which is controlling the autoreactivity. So based on this, Sakaguchi hypothesized that thymus produces cells which control autoimmunity in a mice after day 3. Very simple hypothesis. And for the next decade, he worked to identify these cells. And at that time, in mice, there were 2 types of cells which were recognized. They were called LIT1 and LIT2. LYT2 were what we know as the CD8 cells. LYT1 were CD5 cells. CD4 was not recognized at that time. And what they showed is that if you just take out the LYT1 cells and give LYT2 cells, there will be severe autoimmunity. If you add the LYT1 cells, that is the non-CD8 part, the autoimmunity will be controlled. Now, the counter question to that by the scientific community was that 80% of the cells are non-LYT2 or LYT1. So how come 80% of the cells are suppressive? How is it even possible? So the whole concept was rejected. Said nothing of that sort exists. T cells are controlled by clonal deletion if they're autoreactive, full stop. Sakaguchi in 1993 published that within this LYT subset of mice cells, there are some cells which are expressing high amount of IL-2 receptor or CD25, IL-2 receptor alpha as it is, CD25. And they constituted about 5 to 10, that time CD4 was recognized, so constituted 5 to 10% of CD4 cells and 1% of total lymphocytes. And then through a series of experiments thereafter, he showed that these 5% of CD4 cells, if they were given to mice who were thymectomized on day 3, who are going to develop autoreactivity, did not develop autoreactivity. And there was the birth of the regulatory T cells recognized as CD4 positive, CD25 high subset of lymphocytes circulating in mice as well as in humans. And they were responsible for controlling autoreactivity. And this is the great man because of whom we are doing what we are doing today, who along with Mary Bronco got the Nobel Prize for peripheral tolerance. Now coming to, was that enough to identify regulatory T cells? So Mary Bronco is a geneticist. She's not an immunologist. So there was a thing called scurfy mice, which was identified in the 1940s. Why the scurfy mice would develop a skin rash? This is the scurfy mice. Hair would fall off, sick, wasting mice, polyendocrinopathy, dermatitis. Why the hell are they having it? No one understood for 4 decades. Till Mary Bronco identified that in the X chromosome, there was a gene called FOXP3. Forkhead FOXP3. This particular gene was deficient or mutated in these mice, or the scurfy mice. And soon they identified that there is a syndrome in children, human, which are happening called IPEX. Immune deficiency, immune dysfunction, polyendocrinopathy, X-linked disorder, same gene FOXP3, same mutation, mice and human. That's where Mary Bronco's contribution was to identification of FOXP3. But knowing that FOXP3 deficiency is causing this particular syndrome or autoreactivity was not enough. And then stepped in Sakaguchi again. What did he say, or what did he find? He said that this FOXP3 expression, the gene is there everywhere. It's mutated. If it's mutated, it's in all cells. We know that. Germline mutations happen in all the cells. But their expression was there only on this 5% of 4 positive, 25 positive cells, or TREGs. And TREGs were completely identified by their expression of CD4, high CD25, and FOXP3. If FOXP3 was deficient, these cells would not develop TREG-like characters. So that completed the definition of regulatory T cells in 1993-95, when, this was in 2003 to 2005, when I have almost, completed most of my transplant journey. And subsequently, in the quest of these cells as to what is happening, the understanding of the fact that TREGs originate from the thymus started. Now, what was happening in the thymus? So, in the thymus, as we know that the common lymphocyte progenitor, when it passes through the thymus, it expresses Notch1, it is committed towards the T cell lineage. And when these T cells are faced with self-MHCs, now they go through a series of tests. Like you go from class 1 to class 2 to class 3 to class 10, they undergo a series of tests. And what's that test? Can you recognize self-MHC? 90% of the cells cannot recognize self-MHC. They are dumb, dull, thrown out of the school, death by ignorance. 5% of these cells recognize the self-MHC and behave themselves. That's they don't react vigorously to them. So these are the cells that are allowed to go through the thymus. And another 5% of them would show very high affinity, very strong reaction to self-MHC. These are autoreactive T cells. They would be undergoing negative selection. So only these 5% of all the T cells which go through the thymus will undergo further maturation to develop into the conventional T cells, but that is not all. Once they're out of the thymic cortex, they have to go through the thymic medulla. Now, MHC recognition is not enough. What about the tissue antigens? It was only in the 1980s it was recognized that there is an amazing system of nature called autoimmune regulator. This transcription factor called autoimmune regulator would transcribe any and every tissue antigen in the medullary thymic epithelial cells. And these medullary thymic epithelial cells will present tissue antigens, whether it's liver, whether it's kidney, whether it's brain or heart or lungs, to the T cells which have passed the test in the cortex and have come into the medulla. And once they pass this test that they are not reacting to the tissue antigens, they would finally mature into a single CD4 or CD8, a single lineage cell, and get into the periphery. So that's the story of the T cells. But the story is not complete over here. A very small percentage of those T cells, which do not react vigorously and do not react very gently, or they are of intermediate reactivity, these cells would survive. And these cells would undergo a particular sort of training, like a very regimented military training, as you might call. So these cells subsequently express FOXP3 if they ligate with CD28 firmly, and they would express certain surface receptors. And because of their expression of CD25, they are very, very sensitive to interleukin-2. And with very little of interleukin-2 that is there in the thymic cortex, they would survive. And those cells which survive with intermediate affinity in the thymic cortex would ultimately come in the periphery as thymic T regulatory cells or thymic TREGs. So I have already told you about the negative selection in the thymus, but in the periphery, what happens? So I've spoken about the TREGs, but I'm talking about the peripheral tolerance right now. So when the cells, T cells, conventional T cells, meet with the low level of antigen, they are not able to react fully, and they are ignored, or they are called their tolerance by ignorance. The second process is when they meet the antigen, they react to the antigen, they are ready to pass on their cell signal, but they lack co-stimulation through the S28, 80, 86, they become anergic. And the third process is where they are activated and they are exposed to a lot of IL-2. The IL-2 itself will cause activation-induced cell death or clonal cell death. So these are the ways the peripheral tolerance develops. But the most important process is the process of suppression mediated by the thymic TREGs. So I've briefly shown over here, because this is very important from a transplant point of view, that what is clonal anergy, what is adaptive tolerance, and what is exhaustion. Now, clonal anergy is a process where, the cells can still come back to their normalcy if they're exposed to a good amount of IL-2. They are ready to come out of it. But adaptive tolerance is a state of more permanent tolerance or inactivity. They are not going to react to the particular antigen, provided the antigen is persistently there. And exhaustion is a process where the complete process of activation has taken place. The cell has neither died nor gone into a memory state. They are simply kept in the exhausted state by the expression of a number of receptors which help to keep the cells alive, hibernating, and ready to act if the checkpoint, the exhaustion checkpoint, is lifted. So these TREGs, I'm coming back to them, they have a series of antigen exposure in the form of CD25, as I've already mentioned, CTLA4, GITR, and Helios, and CD39. Now, amongst them, mind you, CTLA4 is a co-inhibitory molecule which is expressed on conventional T cells after the first step of co-stimulation of CD28, 80, 86 binding once they're activated. This is constitutively expressed on T regulatory cells. And same with CD39. What is the job of CD39? CD39 converts ATP to AMP, and CD73 converts it further to adenosine. Now, adenosine is a suppressive molecule, ATP is an inflammasome. So the TREG is completely armored with molecules which will tilt the entire mechanism towards the suppressive lineage. So when we look at TREGs, there is something very, very important, interesting, which is that TREGs need IL-2 to survive. Naive T cells do not need IL-2 to survive. It's only when they're activated they need IL-2. But TREGs survive on IL-2. Who produces IL-2? IL-2 is produced by the activated T cells. Now, it would be natural to presume that the TREGs should produce their own IL-2. But no, the IL-2 transcription is inhibited by who? Who inhibits IL-2 transcription in TREGs? They are the FOXP3 molecules. The defining molecule for TREGs prevents TREGs from producing their own IL-2. And can you guess why nature has done it this way? They have done it because TREGs have to keep them limited in number and amount. If TREGs overwhelm the system, the human ability to fight pathogens would be lost. So TREGs survive on IL-2, but they don't produce IL-2. They will survive, they will proliferate only when there are T cell activation. There'll be more IL-2, they'll compete with T cells for the IL-2, and they would then proliferate and do their job. But thymic TREGs, are they enough? Thymic TREGs were produced originally to fight autoreactive T cells which have gone out in the periphery in the first 3 days after birth. But what about pathogens? We are living in a pathogen-rich environment. To tackle pathogen-induced inflammation or to help the human immune system to cohabit with the pathogens, we need another form of TREGs called the peripheral TREGs, which are regulatory T cell developing from naive CD4 cells, where in the presence of TGF-beta and IL-2 with TCR ligation, they express FOXP3, high CD25, and mind you, for this, a constant source of TGF-beta is needed. So they are indistinguishable from thymic TREGs in all forms and shape. So these are largely responsible for our peripheral fight. And when we compare P-TREGs and T-TREGs, we find what I told you just now, that pathogen, TGF-beta, and P-TREGs or peripheral TREGs are not so much dependent on co-stimulation. The affinity of TCR is far greater in T-TREGs or thymic TREGs than peripheral TREGs. But the major difference lies in the epigenetics, which I'll take you through briefly in the next couple of slides. Now, the FOXP3 gene has got 4 non-coding conserved regions, or called CNSs. Now, the most important ones, as I said, I cannot go into big details. The FOXP3 promoter region and pioneer element, which you see in the 2 corners, they are responsible for the production and survival of TREGs. Without them, there'll be no TREGs. But CNS1, which you see over here, and I'll just briefly mention, most of you possibly know already, that the genetic expression or the expression of genes is dependent on methylation or demethylation. Demethylation will result in the transcription of the gene. Acetylation of the histones will result in transcription of the gene. Methylation will result in repression of the gene. Deacetylation will do the same. So this particular region called CNS1 of the FOXP3 gene does not have any CpG island, means they cannot be methylated or demethylated. They're completely dependent on acetylation. And this is the crux of the pre-P-TREGs. Without this region, there'll be no P-TREGs. And this TSDR, that is the Treg sensitive demethylation region, is responsible for the stability of tregs. So these two regions are responsible for production of Tregs, sustenance of Tregs, and CNS2 for stability of both Tregs and Tregs. And I can't go into much detail as I see there is not much time. FOXP3 is essential, but it is not enough to create tregs as they are. Means they are not enough to endow tregs with a complete suppressive property. To create stable tregs, the FOXP3 needs cofactors. Now it itself induces cofactors binding to the promoter region, and these cofactors in turn bind to the FOXP3 promoter region, CNS1 or CNS2, and increase FOXP3 expression. So they act mutually supporting each other. And this is the process by which tregs becomes tregs. So now in these factors, there are a whole host of factors, most important being CREL or NFAT, or AP1, SMAD3, you name it. I mean, there are a whole host of factors. So that is how the epigenetics of the T regulatory cells are defining their suppressive property. Coming back to pregnancy, this was an amazing finding in the 1990s by Samstein, where they showed that non-placental mammals did not have CNS1 region of the FOXP3 molecule, did not have the CNS1 region. CNS1 was transcribed only in placental mammals. And it is through the expression of CNS1 in the conventional T cells during pregnancy that the Tregs are upregulated, heavily upregulated, which controls the maternal T cell immunity against the paternal antigens in the fetus. And towards the time of delivery, there is a sudden drop of CNS1 expression in these cells, and there is, in a way, rejection of the fetus or delivery of the fetus. That is what peripheral tregs or tregs do to survive the human race. But saying that, tregs are extremely plastic. Fidelity is a big questionable thing. So the entire quest right now of the immunology community or the transplant immunology community is to identify how can we achieve stability of the tregs, or what are the markers of stability of tregs. So for example, if a treg-like cell which is all expressing FOXP3 and STAT5 is exposed to very high amount of IL-6 as you would have it in the peri-transplant period after conditioning, they would go into IL-17 pathway. And a ROR gamma STAT3 expressing cell, which is otherwise destined for Th17, if they're expressed to high amounts of IL-10 and TGF-beta, will go into a treg-like status. So this lineage switch between Tregs and Th17 is something which is an open field for exploration, identification, and plays a huge role in our understanding of treg stability. So which tregs are stable? This we have all tried to understand for a long time. And Edinger and Hoffman from Germany, they showed that the CD45 expressing tregs, if you are expanding tregs, mind you, we can expand tregs with exposing them to CD28, CD3 agonist and IL-2, tregs can expand. Now, when tregs expand, they often lose their treg-like property, which we don't simply understand. But these CD45 positive tregs have been shown to be stable tregs. And when we looked in a study of ours into the donor RA positive tregs, we found that if the donor had high amount of RA positive tregs, there was much less alloreactivity, and RA positive tregs are much higher in cord blood and in younger donors compared to older donors. And we had hypothesized way back in some 10 years back that when we all say that age matters in the donor, it is partly because of the expression of CD45 traits that you get less cell reactivity in younger donor. So in brief, if I talk of the mechanism of action of TREGs, you'll see that the TREGs compete with the conventional T cells or T effector cells to consume IL-2 and not allow them to proliferate. They bind, the CTLA4 in TREG binds to the AT86 and does not allow T cells to bind with the CD28 molecule. They would express PD-1 inherently and not allow they would bind to PDL1 and not allow the conventional T cells to do their job. And finally, they would produce adenosine from ATP to create a suppressive milieu for the conventional or effector T cells. And they also play an important role in tissue repair, which I can't go into details right now. So finally, you can understand through all this that how TREGs are playing an important role in controlling the donor T cell alloreactivity against the host. So with that background, if we go look at the role of TREGs in GVHD, you will see that if we are not having adequate functional TREGs, there is very great likelihood that there will be more donor T cell alloreactivity. And based on the fact that TREGs are controlling the T cell alloreactivity, the Perugia group, Massimo Martelli, Abarza, and Velarde carried out a fantastic model of transplant where they give conditioning as they would do, which is more immunosuppressive conditioning. And on day -3, they would give 2 into 10 to the power 6 T regulatory cells per kg. And on day 0, they would give CD34 cells. And the next day, they would give the conventional T cell at 1 million cells per kg. And what this showed is we call it the TREG-TCON transplant, is that compared to a CD34 depleted or CD34 selected transplant, the incidence of relapse was significantly lower. In other words, we could give conventional T cells in an amount which cannot be given otherwise with a CD34 selected graft. This was done without any immunosuppression, mind you, post-transplant, showing that regulatory T cells are controlling the GVH effect and still allowing the GVL effect to take place. And you all know about how PTCY works. And when we used PTCY in our transplant program, initially in children, we found a significant degree of alloreactivity, which led us to hypothesize that do we always need to get rid of the T cells to achieve a tolerance? We targeted the co-stimulatory pathway in the form of blocking CD28 and AT86 binding with CTLA4 Ig, which is a humanized protein with the Fc fragment of IgG1, the CTLA4 protein, which I spoke about just now, which basically blocks T cell activation. So when we used it in conjunction with PTCY, we found that if we have a combination of sirolimus, which blocks the mTOR pathway, CTLA4 Ig, which blocks the CD28 pathway, and we use PTCY to take care of the alloreactive cells. Despite of this, we have high amount of regulatory T cells post PTCY because the TREGs express high amount of aldehyde dehydrogenase. And based on this protocol, we carried out a non-malignant transplant program where we used AIBTraCT at a long extended protocol on day 0, day 5, 21, 35, 60, 90, 120, 150, 180. and used sirolimus and PDCY with results which were excellent. You can refer to this publication, but what I'll show you over here is that patients who reconstituted regulatory T cells in high numbers did not develop chronic GVHD. Why I'm referring to chronic GVHD is because there were virtually no acute GVHD in this protocol. We found that patients who were younger had better reconstitution of TREGs. Patients who reconstituted TREGs had much lower incidence of chronic GVHD. And at the same time, when we carried out malignant transplants with abatacept prime DLI, we found that there was a type of NK cells called adaptive NK cells which came up, which were responsible for lower incidence of relapse. And these adaptive NK cells, as I said, I don't have much time to go into details. We'll possibly talk about it at some other stage, are a unique type of NK cells which develop in the human system and also in mice in response to cytomegalovirus infection, which are different from conventional NK cells because they can survive. They expand in response to the re-exposure to antigen, the CMV antigen or other viral antigens, or even cancer antigens. They would contract, expand, recall, response, contract, and they persist for a very long time, and they're characterized by expression of NKG2C on the surface and downregulation of the counter-inhibitory molecule NKG2A. So these are the adaptive NK cells. Now, the talk today does not focus on adaptive NK cells. The adaptive NK cells are being shown here to demonstrate the role of TREGs and the counter-interactive pathways which decide the transplant outcome. Now, this particular gene for NKG2C is expressed on chromosome 12. We call the KLRC2 gene, which can be deleted in 30% of the population, means they would not produce these cells. So when we looked at transplant from donors who had high expression of adaptive NK cells and they were of wild type genotype, there was 95% survival, whereas those who had low adaptive NK cells and they had deletion of KLRC2, they had poor survival, and this was largely due to alloreactivity or GVHD and similar phenomena. So when we, I'll skip this slide because it needs a lot more description, but I'll show this one that, mind you, where we have adequate adaptive NK cells, the T cell Th1/M1 pathway is downregulated, whereas if you do not have adequate adaptive NK cells, these pathways upregulated, Th1/M1. And that's the reason why there was more GVHD in this particular group of patients. And likewise, in this group of patients, the regulatory T cell pathway is downregulated. Those who have adequate adaptive NK cells, the T regulatory pathway is upregulated. Or in other words, the Th1/M1 and the T regulatory pathways, they run in opposite to each other. So if T regulatory pathway is upregulated, Th1 is downregulated. So if you have less GVHD because TREGs are upregulated, you will have less GVL effect because Th1 is downregulated. But if the GVL pathway is mediated by adaptive NK cells, then you have a situation where the graft versus leukemia pathway through the adaptive NK cells is upregulated, and so are the TREGs, because the suppressive effect of TREGs is seen in Th1, or the conventional T cells is seen in the conventional NK cells, but not in the adaptive NK cells. So by this particular mechanism, what we have achieved is a possible dissociation of GVHD and GVL, the GVHD being controlled by the T regulatory cells and the GVL effect being mediated by the adaptive NK cells. And in cohesion of this, if you can achieve a donor like this, the results are fantastic. So With that, I will finally come to the fact that regulatory T cells can be isolated and infused, that regulatory T cells can be grown in a polyclonal fashion, antigen-specific fashion, or even engineered with CAR molecules to produce very antigen-specific T cell TREGs. And we have used TREGs in patients with GVHD. This shows a very severe grade 4 GVHD, and following TREG therapy achieved complete remission day 45 and day 62, literally in 17 days. So with that, I will end my talk over here. I think I have not exceeded too much time. And I thank my entire team, particularly Dr. Mehak Agarwal, who has been instrumental in helping me with this work, and Dr. Sarita Jaiswal, and the rest of the team. Thank you very much.
Thank you, sir, for this fascinating talk. And I think we'll start by I'll ask a few questions before we have more questions in the chat box. So, I mean,
Yeah, Dr. Rijit, can I ask a question? Just one basic. In the initial, at the initiation of the talk, uh, uh, sir said that mother is considered as a better donor. So, is it how to explain that?
Mother is a better donor because the child is tolerant to the mother, by default. So a chance of rejecting the mother's graft is very little. Now, there is obviously a chance of mother causing alloreactivity against the child depending on the number of pregnancies. So if it is a multiparous mother, if it is that's the only child and you are transplanting from the mother, then the chance of having a very successful outcome either way is very high. That is no rejection, no GVHD. But if it's a multiparous mother who has, and especially if this child is a firstborn child, then there is very high chance that the mother would exert an alloreactive effect on the child cells.
So the conventionally we know that the father is a better choice than the mother. So it is a multiparous that that is important rather than father
Yes,
person.
I mean, there is no binary over here that like father is better or mother is better. Like it depends on the transplant protocol, really. The Perugia protocol, which was completely T cell depleted, their mother was a better donor. Now, in the Chinese sort of protocol or the PTCY protocol, where you're doing a T deplete transplant, there the female graft or the multiparous mother graft would incur a risk of alloreactivity.
right. So I think I'll start off by asking, sir, when we're doing a transplant with the conventional PTCY platform, so we have been trained to understand that the alloreactive T cells would expand, and by day 5, when the expansion is quite significant, then the PTCY comes in and kicks in and kills them. So, what would be the effect of PTCY on the Tregs, and how does that influence the GVHD?
See, by and large, the reason why PTCY reduces GVHD is because the Tregs are spared to a large extent. Okay, Tregs do not immediately come into play. Means if Tregs were to proliferate in the first 72 hours like the alloreactive T cells, then obviously Tregs would be affected. Those which proliferate, so whichever cell is proliferating would be affected. Now the Tregs come into play a little later. So as you also saw in the mice experiment, the Tregs come into play a little later. So Tregs are spared by PTCY. So that's one of the things. Of course, it depends on how much of Tregs we are giving with the graft. It's not just that giving PTCY will solve the problem, because with PTCY, you have seen a lot of patients develop GVHD. So it's not that it's a blanket, response against GVHD. It also depends on the quality of the graft. what all cells are coming with the graft, etc. What is the nature of the Tregs? We very firmly believe that the functional quality of Tregs is very important, that whether they are 45RA expressing, which will be much more stable, because Tregs in an inflammatory milieu can, go down the Th17 pathway also. They are not fully committal. So younger donors, CD45RA Tregs, they are more likely to offer a benefit in terms of GVHD.
Right. So, sir, as you mentioned about, so when we are faced with the scenario of haplotransplants, luckily we would have probably more than one potential haplo donors for a patient who is undergoing a transplant. So, do you feel that it's worthwhile exploring the potential, cellular composition from each of these haplodonors before selecting a graft? And what would be how do you decide on a haplodonor essentially when you're doing a PTCY graft?
Okay, see, Arijit, we have been doing it for the last 10 years. We fully analyze the graft with respect to their Tregs and natural killer cells. As I said, we pivot on 2 or 3 things. One is the KLRC2 genotype. So if they're KLRC2 wild type, they pass the test. Now, if they're KLRC2 even deleted type, but they have adequate amount of natural killer adaptive natural killer cells, and they have good amount of Tregs, so they would be the donor of choice. Now, out of 3, 4, 5 donors, we don't go by age. We go by the cellular composition of the graft. Means we go by the cellular repertoire of the donor at that point of time. And we do take some measures. If we select a particular donor, if we do not have the option of getting the best donor, we do take some measures to optimize Tregs or optimize adaptive NK cells in the individuals pre-transplant if we have the time. So to me, the composition of the cells or the graft is the most important thing. If we get the right mixture of things, we'll do good. If we don't, we can do anything, but we'll not succeed.
So you mean when you said the composition of the graft, you would probably go by the immune repertoire of the peripheral blood in the donor before deciding? Okay, right. Rajiv, so you were asking a question, right?
Yeah. So we need to go through the questions which is mentioned over here, and please mention the name of the person who has posted the question.
Perfect. So we have one question which has come in from Dr. Raghuveer Prabhu asking, so in a haplodonor, who would be the better donor, parents versus a non-identical twin? I believe the question is with respect to the tolerance. Yeah.
So, with PTCY, getting a graft in is not a big issue. Rejection, I don't think, is a big problem, especially if you're doing myeloablation and adequate immunosuppression. Rejection is not an issue. Now, the issue is, of course, GVHD versus GVL. And as I said, that we would go by the repertoire of the way we do beta PTCY transplant. We are dependent on the NK cells. We are co-stimulation blocking the T cells. So we are not recruiting T cells for a GVL effect. Our GVL effect in our transplants is mediated by NK cells. So we go by the NK cell repertoire, and we also look at the regulatory T cells in the donor. So the question that Prabhu asked, we just don't go by the relationship. Okay, by default, a non-identical twin would have theoretically greater chance of mutual tolerance to each other. So if it's a non-malignant transplant, I would definitely select the non-identical twin if it fulfills certain criteria. But if both parents and the non-identical twin, they have the same repertoire of NK as well as the Tregs in their peripheral blood, I would go with the non-identical twin over the parents.
Perfect. And we'll take the next question from Dr. Gaurav, who has asked, would you prefer doing a KIR typing in haplotransplant in your protocol?
See, the thing is, I did not go into KIRs right now. Doing a KIR typing in a standard PTCY transplant doesn't make much sense. We do it because, as I said, ours is NK driven. So if you're doing an NK driven transplant, means you are doing a T cell depleted, TCR alpha beta depleted transplant. KIR genotyping is important because then choosing a haplotype B donor for a malignant disease is important. Now, mind you, as regards NK alloreactivity or NK ligand mismatch, we don't prefer NK ligand mismatch donors in our transplant protocol. It's a conventional wisdom that you choose an NK ligand mismatch donor and you get a better outcome in terms of a GBL effect. We have not found it in our protocol. So we don't prefer an NK alloreactive donor. So it differs from a transplant platform to another. In CD34 selected graft, they found in Perugia, but in the co-stimulatory blockade situation, we don't find it. But by and large, if you ask me that what is the advantage of doing a KIR typing, if you can get a KIR-B donor, it's better because you have a whole range of activating receptors.
Right. And sir, you mentioned this in context of a non-PTCY platform or also with respect to a PTCY platform?
In the KIR-B donors.
Yeah.
Yeah, KIR-B donor, see, there is no harm in getting a KIR-B donor because you are getting a possibility of a NK cell mediated antiviral, anti-leukemia effect through the wide range of activating donors. But saying that, it is a surrogate. It's not an absolute because the GBL effect takes place through other NK receptors, not just the KIR receptors. So it's not a straightforward linear thing that I can tell in one word that this is better or that is better. But by and large, KIR-B has been seen particularly in haplotransplants, especially if you're doing a T cell depleted transplant, to be better than a KIR-A donor. And in our hands, KIR-B has been shown to have better relapse-free survival than KIR-A.
Right. Yeah. Start with the first question, Ankita, Dr. Ankita.
Yeah, I think I could not answer understand this question, so it's probably skipped it. So Dr. Ankit has asked between T effector cells, I don't know what Tx is, and Treg cells, which one fights tumors the most?
Tregs don't really fight the tumor. I don't know what Tx is. That anti-tumor effect, if it has to be, is through the T effector cells. So I also don't understand much about it.
Yeah. So sir, one more question. I think I find it interesting. So from Dr. Kanaram, he asked if he appreciates the topic and the lecture, and asks how abatacept is useful in non-malignant setting where GVL is not required. So I believe he's asking about abatacept with DLI.
No, we don't use DLI in non-malignant. It is pure abeta PTCY sirolimus. It's a beautiful platform to induce tolerance.
And reduce GVHT effectively at the
yes.
Yeah, right. So how to use DLI safely in haplotransplants with dropping chimerism?
There is, I wish I could answer it with sort of automobile certainty that when you are driving in first gear, second gear, third gear, or fourth gear, how much speed you should drive at. No, there is nothing like that. If DLI in a T depleted platform, okay. So DLI, it's a very interesting, very good question. I might talk about it for half an hour. So when the Perugia group did this sort of transplants with CD34 selected graft, even beyond 100 days, when they gave the slightest amount of DLI, there was severe GVHD. So there has been absolutely zero T cell tolerance which has developed because there's no donor T cells. Now, in that situation, even a drop can be poisonous. But when you are doing it in a PTCY setup, where there is sufficient donor-recipient interaction, there has been a degree of tolerance which has developed through that. I mean, we have used it as early as day 21. Yes, there is a risk of GVHD, but it depends on the situation. You start with a very low dose. You start with 1 times 10 to the power 5 million cells per kilogram, and then gradually build it up. That would be my advice. Don't go for a high dose straight away.
So just to clarify, you're mentioning about plain DLI, or would be abatacept prime DLI?
No, I'm talking of plain DLI here.
Okay.
I'm talking of plain DLI. Abatacept prime DLI is basically NK cells.
Yeah.
So giving NK cells in the middle of T cells is no gooder, because NK cells would be lost amidst the T cells. So NK cells best work in a lymphopenic environment. That's why we give it on day plus.
Yeah. So, Dr. I think Dr. Srijit Mukherjee has asked, in benign diseases like hemoglobinopathy transplant, would be your take on NK matching? And I believe he's talking about haploidentical setting. So I think partly was answered by Sir in his previous.
No, this is again a very, very interesting question. I mean, these guys are asking very good questions. So, see, the thing is, we avoid NK alloreactive or NK ligand mismatch donor in benign diseases. So NK alloreactive donor we have seen to be associated with higher alloreactivity in PTCY platform. So we do not want any GVL effect over here. We avoid that. So that is our take on it. And I think there is another very good question by someone called Chandrachud Poddar just before that. Have you seen that, Arijit? There is a very good question just above Malini Garg.
So I think he's asked, are we using letermovir more and more? As we are using letermovir more and more, CMV reactivations are helpful for adaptive NK cells. So what's your take on that?
So he's avoiding the.
It is a brilliant question. I mean, CMV reactivation is associated with lower relapse in acute myeloid leukemia patients because of the adaptive NK cells. It has been shown by various groups. I mean, 3 groups are working on it, ourselves, Jeffrey Millers, and a group from Germany. So we have all shown that because we are ubiquitous with CMV. Okay, so we are all CMV seropositive. In West, it's only 50%. So they do not get so much of adaptive and NK cell benefit. I mean, if genetically we are wild type and we have adequate adaptive NK cells are not only good for the leukemia, particularly AML, they're good for CMV as well. The adaptive NK cells take time to recover, means it takes at least 60 to 90 days to come up to an extent where they can exert their effects. So we don't use letermovir. Okay, we don't mind CMV, we monitor CMV, we use ganciclovir, we use whatever. We don't use letermovir for the very reason what he has mentioned. And that's why I said it's a very good question. In our transplant platform, we would like CMV reactivation as early as possible to get the best GVL effect through adaptive NK cells.
Right. So also interestingly, when you've used the adaptive immune cells, what would be your experience of CMV reactivation? Would you see it as much as you would normally see with a conventional PTCY platform, or would it be much less because you're using an innate immunity to be probably counteracting the initial viral reactivations?
This is not innate immunity. This is adaptive immunity. CMV specific adaptive immunity. Yeah. Adaptive NK cells are CMV specific. They're born out of CMV. Now, almost 70-80% would have CMV reactivation, but none of them are to a level where we need to worry about. So, as I said, we monitor CMV. We want CMV to be reactivated. We do not prefer CMV seronegative donors in our transplant platform. We want CMV seropositive donors. We want early CMV reactivation. So if the donor is deleted for the gene for adaptive NK cells, then there might be a problem. Then there there is no CMV supported adaptive NK cells. And in that situation, you prevent the CMV, then the entire mechanism has to be through the T cells, whether it's anti-CMV or anti-leukemia. So here we are banking heavily on a CMV seropositive donor and early CMV reactivation. These are the two key factors in the anti-leukemia effect. So we get means we love to get 100% CMV reactivation. Our CMV reactivation is around 80%. So we love it.
Interesting how you say you love CMA reactivation because I think it's been a great worry for us when it's an early reactivation.
I mean, because as I said, I mean, if you can utilize adaptive NK cells in this platform, that controls the CMV better than anything else.
Right. So also you pointed about the use of Tregs, which have been expanded in vitro and then given back. So this adaptive cell transfer. What's your take on it for I mean, outside the realm of infusing it in vivo? I mean, sort of let it expand in vivo. What would be your take on adaptive transfer and apart from the fact that it's costly, would there be any inhibitions on the use of Tregs post-transplant as an infusion or pre-transplant? I mean, as you see it best.
So here, what has been shown is that Tregs are more preventive or prophylactic than therapeutic in the field of transplant. So if you give Tregs 48 hours to 72 hours before that conventional T cells, you get the best results in terms of control of GVH, maintenance of GVL. When it has been used prophylactically or preemptively post-transplant, it has not worked that well. But we have used it in, refractory GVHD with good results. Means once the GVHD has set in, using it as a therapeutic measure, yes, but using it as a preemptive measure has not worked. Means if you think that you will give, say, Tregs on day +7 or day +15 and will prevent GVHD, no. If you have to prevent GVHD, you have to give it before giving the T cells.
Right. Also, sir, when you mentioned you've used it in the setting of a GVHD, most often these patients are also on steroids. So what would be your take on, so if, for example, you're contemplating infusing the Tregs, would you want to come down on the steroids very fast before infusing it, or you'd be okay with that?
No. I mean, steroids, particularly dexamethasone in particular, promotes Treg proliferation. So they are pro-Treg. So Dexa-Treg combination is very good combination.
Okay. Right.
I mean, even rabbit ATG of the Genzyme variety, means the thymogam, it has been shown to be Treg sparing.
Yeah.
So in one of the patients, we have used low-dose thymogam for a refractory GVHD. 3 doses of low dose 0.5 into 3 1.5 alternate days, and then after another 3 days we have infused Tregs with within 2 weeks the gut came back to normal.
And this is in the setting of GVHD.
Refractory grade 4.
Right. Also, sir, I mean, as you mentioned in passing that you were using sirolimus, and I believe you've explained that to me in the past. So could you please, why exactly would you prefer sirolimus as compared to cyclosporin or tacrolimus? If you
See, the thing with CNI is that CNI does not allow the TCR mediated signaling. So unless you have TCR mediated signaling, you cannot develop the tolerance or energy either. So the TCR mediated signaling is essential, which the CNI does not. It's very good at preventing activation, but then it will never allow you to develop tolerance because of the lack of TCR mediated signaling. Now in sirolimus, it's blocking the mTOR pathway. Now the mTOR pathway is absolutely critical for natural killer cells. It's absolutely critical for T cells. for their cytotoxicity. But TREGs are spared when you are blocking this pathway. So it's not that they are promoting TREGs, they are sparing TREGs. So TREGs will then have to survive on their own accord. But when they are targeting NK or T effector cells by the mTOR pathway, sirolimus, everolimus, TREGs are spared. And relative sparing of TREGs is what has been shown to promote the tolerance mechanism in this protocol. So if you do not have TREG expansion, what we have seen in our protocol, that patients who are not having early TREG expansion are the ones who are developing chronic GVHD.
So when you mentioned that, sir, so basically, how often do you look at the immune repertoire in the recipient post-transplant? And do you take a call on what happens when you see those results?
We do it monthly. I mean, that has been our protocol to do it monthly. Now, if we find that TREGs are not adequate in amount, what do we do? It's a $1 million question. There is no way that apart from tinkering a bit with sirolimus here and there, you can do a lot because, as I said, that the regulatory T cell infusion preemptively or prophylactically doesn't help. So, we know that these patients are more likely to develop chronic GVHD, so we are much more aware and alert about development of chronic GVHD.
Sorry. Dr. Chandrachud has an interesting comment, as in when you mentioned about CMV acting as a stimulator of NK cells, do you believe a vaccine equivalent to CMV reactivation might help?
Yeah. I mean, so vaccinating a donor who is CMV seronegative is something that can be explored. Now, if it's a post-transplant situation, what we and others have tended to do is expand NK cells with CMV antigens. Okay. Directly vaccinating the patient is not something that has been explored. Donor, yes. In vitro, yes.
Right. If you may allow me to ask, I don't know it's more futuristic or not, but there is some early data on use of CARs, CAR Tregs, and how do you see that panning out in the setting of GVHD post-transplant? I mean, whether, as you mentioned, but it's very interesting because, as you mentioned, preemptively would not help. So, would you see that helping in terms of GVHD once it has developed in patients?
I mean, it is very difficult to say that the GVHD is developing because of T effector cells directed against a particular antigen. In a haplo mismatch, you will have a 5 or 6 antigen mismatch. Now you have to develop a CAR against those 5 or 6 antigens, which is not feasible, right? It has been tried in settings of rheumatoid arthritis where a particular synovial antigen has been targeted, etc. For GVHD, it's best to have polyclonal cells or incubate TREGs with the APCs from the patient in vitro and expand those TREGs in a polyclonal manner or polyclonal antigen-specific manner.
Right. I think there's one more question from Dr. Orithro, who's asked, how relevant is in vivo Treg expansion versus ex vivo develop? So it's versus Treg infusion. So I believe he's trying to ask your thoughts on in vivo T cell expansion, Treg expansion versus adoptive cell infusion through Tregs. What would you prefer and why?
No, I mean, if I can expand it in vivo, nothing like it, but there is nothing that I can do to expand them in vivo other than trying to give sirolimus here and there. So sirolimus is also a multi-edged thing. I mean, that is another discussion that sirolimus, it's not like you give sirolimus and tregs expand, boom, boom. It's nothing like that. It's pairing tregs, that's all. I mean, it doesn't cause a massive expansion of tregs or anything. In fact, that one that could help in treg expansion, gut homing, etc., the retinoic acid. So these are all very gray areas right now. Treg is very underexplored as far as this field is concerned, and because of the car invasion, the car invasion, people have simply, as you said, are going for cars rather than exploring the basics of Tregs, like it has happened with the T cell, the CAR directed at malignancies as well. I mean, what are you doing right now with CAR T cells? Tell me. You are taking CD3 positive cells and transducing them indiscriminately with CARs. You are not picking out even CD4 or CD8. You are not picking out memory or naive. You are not doing any of those. You are doing Joima CAR. You're transducing whatever you can and then giving it with the hoping for the best. And sometimes you're getting CRS icons, sometimes you're getting good results. So we don't know what exactly is going on. We are doing things, but we are not very aware of what's going on at a very basic molecular level.
Right. Thank you, sir. I think that your insight is always fascinating. Rajiv, so you have something to add before we can sort of, because I think we've covered most of the questions. So you want to add your final comments and your take before we sort of can close this session? But nonetheless, excellent talk, sir. I think it's very inspiring for people like us, and because it adds a new dimension to the way of thinking. It's not just about giving the conditioning regimen, putting in the graft, but also thinking and planning ahead. Because I think, as we've always learned, that it's very important to plan, because once you've given the graft and you've done your first few days of graft after the graft infusion, there's very little you can do. It's probably up to the body's immune systems to interact and then and come out. So thank you so much, and I would leave it to Rajiv sir for the final comments.
Yeah,
And
no. Excellent, amazing talk. We learned how much we need to learn to optimize transplant, so that is a great advantage of this talk. Excellent, sir. So I think all the students, all the participants has been benefited from this talk, and we would love to listen to you in future again. So I think we need to arrange a series of lecture on transplant immunology, as Rijit told me. So we are planning to organize that in some forum. Thank you, sir. So if